start whenever. You don't have to worry about it. I just lop off anything at the beginning.
Okay, great. Well, hey guys, it's Rod Quilitz, and I am the Clinical Pharmacy Coordinator for Infectious Disease and Antimicrobial Stewardship at Moffitt Cancer Center across the street. They say that the shorter your title, the more power you have, so you can figure out about where I stand. Today I'm going to talk about invasive fungal infections in cancer patients, which is a subject near and dear to my heart. And I will... Oh, here we are. Okay, so basically what I want to do today is briefly touch on the risk factors predisposing cancer patients to fungal infections, talk about some of the most commonly encountered fungal pathogens in this population, and then compare and contrast the available antifungal agents, looking at spectrum of activity, clinical efficacy, toxicity, drug interactions, and whether or not therapeutic drug monitoring is required or beneficial. Okay, so obviously fungus has been among us for a very long time, over 300 million years, over 2 million species have populated the earth. Basically, I thank fungi for brewer's yeast and for penicillin, and don't ask me to choose between them. But more problematically, in the last few decades of the 20th century, now into the 21st century, we are seeing an increase in new and rare mycoses with substantial morbidity and mortality amongst more and more immunocompromised patients, and now we're starting to see some drug-resistant strains, which are concerning. Okay, so the patients who are going to wind up with invasive fungal infections have some degree of host defense deficit. So the immunodeficiencies can be drug-induced, so I commonly see patients who are neutropenic status post-cytotoxic chemotherapy, but patients who get whole-body radiation, patients with prolonged corticosteroid therapy, patients on immunosuppressive agents such as cyclosporin, tacrolimus, etc., to prevent graft-versus-host disease, or to prevent rejection in solid organ transplant patients, patients with congenital immunodeficiency states such as CGD, SCIDS, MPD, or acquired such as HIV/AIDS, as well as the very young and the very old. So when we look at, in general, relative risk factors for invasive fungal infections, we focus on neutropenia, placing patients at risk, classically for Aspergillosis, for example. And once you get past 7 to 14 days, you start to see a dramatic escalation in the incidence of invasive fungal infections. But also, the lymphocytes have a role here as well. So patients with a very low CD4 count are at higher risk for invasive fungal infections. So both types of white blood cells are important. So in terms of this is just a little cartoon of the fungal cell structure, and just kind of focusing on where different antifungal agents will work, right? So at the level of the cell wall, we have the echinocandins. At the level of the cell membrane, we have the polyenes such as amphotericin. At the level of nucleic acid synthesis, we have flucytosine, and we have ergosterol synthesis is inhibited by the azoles. So we're going to break this down predominantly into yeasts and molds, right? And so the yeasts are unicellular, oval or round in shape predominantly. They form fuzzy matted growth called mycelia, and they reproduce by budding. The molds, on the other hand, consist of thread-like filaments, hyphae, which are divided by transverse walls in the septated molds, or are without divisions in the aseptate molds. Of course, they have a canidia, which are non-motile spores, which are responsible for asexual reproduction in the molds. So this is a list of the major fungal pathogens that we deal with in our patients, and for time constraints, I'm going to focus on Candida, Cryptococcus, Aspergillus, Fusarium, and the Zygomycosis. Although I will mention some of the other agents in passing. So starting with Candida, of course, this is a normal flora, usual part of the skin, the female genital tract, and the gastrointestinal tract. Neutrophils are a critical defense to prevention of invasive candidiasis. We see mucocutaneous candida, such as oropharyngeal, esophageal, vaginal, and more alarming systemic, such as candidiuria, candidemia, and disseminated candidiasis. So in some ICU series, yeast is the fourth most common bloodstream infection, following coag-negative staph, Staph aureus, and enterococci. So certainly in patients who have some of these risk factors, you certainly need to be thinking about candidemia when you have a critically ill patient who's in a rule-out sepsis scenario. So risk factors can be pretty diverse. They include neutropenia, patients with hematological malignancies, diabetics, patients with any variety of reasons for immunodeficiency, or who are on high-dose corticosteroids, immunosuppressants, antineoplastics, have a central venous catheter device in place, who receive hemodialysis or total parenteral nutrition, who've been on prolonged antibacterial therapy that's wiped out the bacterial flora, or have had a recent extensive gastrointestinal tract surgery. Now, in my patient population, back when we used to be able to get people to do autopsies, they found that only of patients who wound up with disseminated candidiasis, only which was found on autopsy, only 25 to 45% of those patients actually had positive blood cultures. So you can have disseminated candidiasis in the absence of positive blood cultures, at least in the neutropenic cancer population. Now, maybe we're doing a better job at capturing that. It's kind of old data, but nonetheless. So disseminated candidiasis. So when candidiasis disseminates, it can go just about anywhere, right? So in the abdomen, we see it popping up as a component of an abscess. We see patients with Candida peritonitis. In the bone, we can have hematogenous spread to the spine, sternum, or femur predominantly. Patients with central venous catheters, of course, can have a CVC-related candidemia. But there's also reports out there of fungal endocarditis or fungal superinfection of bacterial endocarditis, which is a real nightmare kind of scenario. We don't see a lot of Candida in the CNS, but it can happen after neurosurgery, and it has been reported with IV drug users, alcoholics, and premature infants. In terms of Candida can get into the joint, usually status post-trauma or patients with underlying joint disease or who have prosthetic devices. And this is usually a monoarthritis. You don't expect to see it bilaterally. Candida pneumonia. I hope we can all agree that is essentially not a real scenario, right? However, you can have hematogenous spread, essentially like a septic emboli kind of picture, which I'll show you on the next slide. Also, urinary tract infections, true urinary tract infections with Candida are very rare, right? I mean, diabetics are at risk, patients with hydronephrosis, patients with indwelling catheters. Mostly it's about getting those catheters out, patients with stones. But for the most part, be skeptical of that kind of finding. In terms of disseminated candidiasis, so on the leftmost slide, you're going to see a classic example of what we used to call hepatic splenic candidiasis before the term disseminated candidiasis took over in vogue. So you can see in the patient's liver, you can see all those holes, the classic Swiss cheese liver, and that is the result of neutrophils attacking the yeast. So you do not see this image in a neutropenic patient. You see this image in a patient shortly after neutropenia has resolved, if they have disseminated candidiasis. In the upper right-hand corner, you see all those cannonball-looking, very, very round lesions. So that's where you can get a patient who has disseminated candidiasis, and these nodules go to their lungs, but they can also go to their skin, any number of the locations we talked about in the last slide. It doesn't tend to be a subtle diagnosis. Also, Candida, disseminated Candida go to the eye. This is an ophthalmologic exam is a required part of the treatment of candidemia, especially in the non-neutropenic cancer patient. Okay, So in terms of immunocompromised patients, looking at solid organ transplant patients and stem cell transplant patients, the incidence of invasive candidiasis is low because of the utilization of predominantly fluconazole prophylaxis in high-risk patients. However, the attributable mortality was about 24%. So it's something we certainly take very seriously in the immunocompromised patient population. Anytime we talk about Candida, I think it's really important to talk about the antifungal spectrum of agents that have activity against Candida, because I think there's a lot of misunderstanding here, right? Because so many of our colleagues here, it's either Candida albicans or Candida non-albicans. So fluconazole susceptible, fluconazole resistant, and the story moving on. But really, that's not the case, right? So Candida albicans, Candida kaffir, Candida dublinensis, Candida tropicalis, they are usually exquisitely sensitive to fluconazole, to the other azoles, to echinocandins, and to amphotericin. So that's a lot of non-C. albicans fluconazole susceptible Candida out there. Now, Candida glabrata, right? Candida glabrata may have azole resistance via the production of efflux pumps. So you can wind up with a scenario where you have Candida glabrata can still be susceptible to fluconazole, but very often it's sensitive dose dependent, meaning that you can overwhelm these efflux pumps with a high enough dose, and that's where we start getting to doses like 800 milligrams per day, for example. Now, if you do have these efflux pumps, they may also pump out some of the other azoles, itraconazole, voriconazole, posaconazole. So you really need susceptibility data to with Candida glabrata if you're going to attempt to use an azole. The echinocandins were generally considered to be the treatment of choice, or amphotericin, and there are some case reports now of a echinocandin-resistant Candida glabrata, which could get ugly. Candida krusei is intrinsically resistant to fluconazole, but voriconazole, posaconazole maintain their activity because it's actually an issue of the target enzyme alteration. So fluconazole won't bind, but voriconazole will, for example. Echinocandins, amphotericin certainly remain options. Candida parapsilosis and Candida garramundae are generally susceptible to all, but they tend to run a little bit higher MIC to the echinocandins. So if you see a breakthrough candidemia on a treatment dose of an echinocandin, more often than not, it's going to be Candida parapsilosis, and once in a great while, Candida garramundae. Another one to mention is Candida lusitaniae, predominantly because it is intrinsically resistant to amphotericin. Good one to know for the boards. Okay. Switching gears to Cryptococcus, right? This is a ubiquitous encapsulated yeast. It's commonly found in the soil and in pigeon droppings, and it's acquired via inhalation. The most common sites of infection would be the lungs, right? The patient's going to have cough, rales, shortness of breath, and the CNS. You can have nonspecific meningeal symptoms, headache, fever, nausea, and vomiting, and altered mental status. We always think about Cryptococcus neoformans, which is the predominant species that we encounter. It's the fourth most common infection in HIV/AIDS patients, second most common fungal infection. But now we also have to worry about Cryptococcus gaddii, right, which popped up in the Pacific Northwest in predominantly immunocompetent patients, and has traveled all the way down to Florida, I can tell you from personal experience. Not my personal infection, but my patient. Okay, in terms of how we treat cryptococcal meningitis, I will definitely refer you to the excellent IDSA guidelines on this subject. But really the hallmark of therapy is the classic is induction with an Amphotericin B formulation, either lipid or not, depending on your patient's risk for nephrotoxicity, in combination with flucytosine, usually that's going to usually be for 2 weeks, followed by a consolidation therapy of 8 weeks with high-dose fluconazole, and generally a prolonged prophylaxis with lower-dose fluconazole based on your patient's CD4 counts. And in transplant patients, the basic concept is very similar, depending on the duration of maintenance therapy is going to be prolonged depending on the level of immunosuppression. For non-meningeal cryptococcus, for mild to moderate, fluconazole can be utilized, prolonged course of fluconazole. But immunosuppressed patients with severe pulmonary cryptococcus or patients who have cryptococcemia, they need to be treated just like the CNS cases. Okay, moving on to one of our major adversaries, Aspergillus. This is another ubiquitous mold found in soil, water, and plants. The species that we most commonly encounter are Fumigatus, Flavus, and Niger, but we need to be aware of Pterius and Ustus. And this can cause superficial infections, like we had a patient fall, scrape his knee on a sidewalk, and wind up with a mold cellulitis at the site. This is an allergen. You can also wind up. Our concern is when you have, say, an Aspergilloma fungus ball in the lungs or the CNS, and you can have invasive disseminated infection with Aspergillosis. This one's kind of a busy slide, but on the right it just shows you some very old data, but still telling that in the absence of prophylaxis, especially, if you're neutropenic long enough, you've got a very high chance of winding up with invasive pulmonary aspergillosis. Now, from a diagnostic standpoint, we rarely are lucky enough to culture out Aspergillus, even in the face of an invasive pulmonary aspergillosis. Sometimes we'll get lucky and we'll have a positive respiratory culture, either sputum or a BAL that's positive that grows Aspergillus. We have to be aware that many patients for whom Aspergillus grows in the sputum or even in like a lung sample, many of these patients are just colonized with Aspergillus, particularly like our lung cancer patients. We get this consult a lot. But even if you aggressively try to work this up and you get a BAL, you biopsy it, you only get the culture results about 40% of the time. So you wind up relying a lot on what are my patient's risk factors and what are their CT scans looking like, right? We do have the galactomannan assay, which is potentially of some use to us in the diagnostic realm. This is a cell wall polysaccharide of Aspergillus. It gives us the opportunity for a possible early diagnosis in high-risk patients where screening might be appropriate. However, we get false positive results in patients receiving piperacillin tazobactam, and decreased sensitivity of this test in patients who are on anti-mold agents. Also, there's a substantial false positive risk just in general, so you need 2 positives in order to really take it seriously. Okay, so on the CT scan, here's a couple of classic images for you to be familiar with, right? So at the top, the halo sign, right? You have a ground glass attenuation surrounding a nodule due to alveolar hemorrhage, right? So Aspergillus is very angioinvasive, and this central area is where most of the bleeding is occurring. That's why it looks more solid on the CT scan. This is an early sign of aspergillosis, and the halo disappears over time, and you wind up with just the solid nodule appearance. And the bottom one there is the air crescent sign. So this indicates a necrotic area, and this is a late sign, and much like what I mentioned with hepatic splenic candidiasis, this is caused by neutrophil attack of the mold, and it's not seen during neutropenia, so it's a late sign. Okay, this is an example of a CNS invasion of Aspergillus, and of course the hemorrhagic areas are quite telling. This is an example of a superficial puncture wound related cutaneous Aspergillus infection. Okay, so bottom line on this slide, Aspergillosis is associated with a significant mortality rate. We may be starting to see a little bit of a decline in the mortality rate with Aspergillus as we have more active and less toxic drugs, so that we're starting therapy at an earlier stage. But still, the more in highly immunocompromised patients, very high risk for mortality. From an antifungal spectrum standpoint, obviously we've lost fluconazole at this point. Itraconazole has some activity, but it's not commonly utilized, especially since we don't have the IV formulation anymore. Voriconazole and posaconazole, extended spectrum azoles, have the best in vitro activity against Aspergillus. The echinocandins are fungistatic against Aspergillus. We'll talk about that later. And of course, the amphotericin formulations had been the treatment of choice for decades until voriconazole came along. I do want to mention on this slide that Aspergillus terreus is intrinsically resistant to Amphotericin B, so it used to be associated with an extremely high mortality rate back when all we had to treat these people with was Amphotericin B, right? With voriconazole, the response rates are the same as any other Aspergillus. I also want you to be aware of a relatively uncommon but clinically important Aspergillus species, Aspergillus ustus. Disseminated Aspergillus ustus has been reported predominantly in allogeneic stem cell transplant recipients who were receiving voriconazole or echinocandin prophylaxis. And the treatment of choice is amphotericin, and most of the data is with lipid formulations of Amphotericin B, partly because these patients are at such risk for nephrotoxicity. Okay, I'm not going to be able to do a lot of clinical trials in this presentation because there's so much to cover, but there's a couple I thought you'd want to know about when we're talking about Aspergillus, and this is the classic. I can't believe it's been 11 years now. Voriconazole versus conventional Amphotericin B for invasive aspergillosis. So they had 277 patients. They randomized them to either get voriconazole or conventional Amphotericin B, 1 to 1.5 mg per kg per day, because that's the kind of dose you need to really treat a mold infection, conventional Ampho B. Patients were able to stay on voriconazole for a median duration of 77 days, conventional Amphotericin B 10 days. Right, 80% of these patients were switched to other licensed antifungal therapy because of toxicity, predominantly nephrotoxicity. So at 12 weeks, you had a higher success rate with the voriconazole group, 53 versus 32%. This was statistically significant, but most importantly, there was a survival difference at 12 weeks, 71% versus 58%, which was statistically significantly higher for voriconazole. So based on this data, voriconazole is considered to be the first-line treatment of choice for invasive aspergillosis. Now, the question that's been raised is there a possibility to improve this by using combination therapy, and specifically combination therapy with an echinocandin? So you have a cell wall active agent and you have a ergosterol synthesis inhibitor, so two completely different mechanisms of action, potential for synergy. All right, well, this is very preliminary data, right? So this data was presented at ESHMID last year, but has not yet been published in a peer-reviewed journal. All right, so take it with a large grain of salt for that reason. They did a prospective randomized double-blind trial in the same exact number of patients as the last trial. This is a weird coincidence. And with proven or probable invasive aspergillosis, those definitions are important. And these patients were randomized to receive voriconazole or voriconazole plus inidilafungin. And same dose of voriconazole as in the last study. The inidilafungin dose was 200 times 1, then 100 milligrams daily, and combination therapy could be administered for 2 to 4 weeks. The week 6 mortality for the entire group was 27.5% for monotherapy versus 19.3% for combination therapy, which is actually pretty impressive. But this was not statistically significant. Okay. Now they scrambled, they did a post hoc analysis, and they looked at 218 out of those 277 patients were diagnosed due to positive galactomannan assay, either from the serum or from the BAL. And looking at that group of patients, which was not predetermined prior to the study, 27.3% mortality in the monotherapy versus 15.7% in the combination therapy. That did get you a p-value less than 0.05. I think this is one of these studies that, number one, let's not make too many conclusions until so we actually see if this ever becomes published. But But I mean, we do know that unfortunately there wasn't a major advantage in mortality with combination therapy, and whether this post hoc analysis holds up is, I think, is subject to further review. I'm going to move on to Fusarium. Fusarium is this banana-shaped mold you see in the photo to the right. Also found in soil, plants, and water. Fusarium can cause superficial infections such as keratitis, onychomycosis. It can be locally invasive or cause disseminated infections in severely immunocompromised patients. The most common species include Fusarium solani in about 50% of patients, Oxysporum 20%, Reticuloides 10%, and Maniliforme 10%. And the species has become somewhat relevant when we talk about susceptibilities, potentially. We get excited in our prolonged neutropenic patients about any kind of infections around the toes, right? You know, because we're thinking Fusarium, 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 right? It's the number one cause of toe lesions near the nail or interdigital in neutropenics. If the nail is involved, we actually will consult podiatry, get that nail out. Number one, it can help us the cultures can be positive for Fusarium. Number two, it can actually act as a nidus of infection, almost like a foreign body, and we may actually improve our chances of treating the infection by getting that nail out. If you have a dermal disseminated lesion, then you're going to need a deep punch biopsy. And Fusarium is kind of unique amongst the molds because you can actually get a positive blood culture if the patient has disseminated Fusarium. It's not guaranteed, but it's certainly worth checking. Okay, so here's an example of one of our red swollen toes, and you see that inflammation is starting to spread from the toe, right? This is a scenario that if the patient doesn't respond to antifungal therapy rapidly, you can wind up having to remove, amputation may be required, right? So it's better to remove a toe than a foot, better to remove a foot than to have the patient die of a progressive infection. This is a gentleman, you see those various spots. These nodules are from disseminated Fusariosis. So how do we treat it? Well, predominantly in the non-malignancy patient, surgical debridement of localized infections, right? It's often not an option for my acute leukemics with a platelet count of 5. So we wind up using Amphotericin B at high doses or a lipid formulation. And generally in practice, lipid formulations are used because you saw what that incidence of nephrotoxicity was with high-dose conventional Amphotericin B in adults. Voriconazole has a potential role, but just be aware that Solani and Reticuloides are usually azole resistant, whereas Oxysporum or Maniliforme tend to be more susceptible to Vori or Posaconazole. The caveat is at this stage of the game, we don't really have the species. We just have Fusarium species reported to us. And in a high-risk prolonged neutropenic patient with a disseminated Fusarious infection, we generally wind up throwing them on both, like a lipid formulation of Amphotericin in combination with Voriconazole. At Moffitt, Ambisome is our formulary, lipid formulation, so we wind up with Ambisome plus Voriconazole, yes. Yes, well, you know, the Amphotericin B lipid complex is still an option, and it's still being used, including at Shands, which is not too far from us. So, combination therapy, as I mentioned, for disseminated disease in high-risk patients. There is some limited data on benefit of adjunctive leukine, granulocyte, macrophage, GCSF, and or interferon gamma for refractory cases. Mostly, like I said, case reports, case series. Okay, so as I mentioned, Voriconazole, Posaconazole have activity, perhaps depending on the species. We don't have Fusarium susceptibility panels readily available to us at this time. Lipid formulation of Amphotericin B. And I'll mention some other molds I'm not going to have time to get into in detail. Cetosporium apospermum is also known as Pseudalschuria boydii, if that helps. It is Voriconazole and Posaconazole have the best activity against this organism, which is intrinsically resistant to Amphotericin B. The cousin of Cetosporium apospermum is Cetosporium prolificans, and unfortunately, this fungus is not particularly susceptible to the antifungals that we have in our arsenal. Right? So we wind up generally using combination therapy with an extended spectrum azole and terbinafine, and we pray the patient gets their neutrophils back before this fungus kills them, which usually does if the patient doesn't rapidly recover from their state of immunosuppression. It's a rare but bad player. We also have the Yeasts Moulds, which you usually only see again in the most profoundly immunocompromised patients, such as Alternaria, Bipolaris, Curvularia, and Exophilia, and the extended spectrum azoles are the drugs of choice. Okay, moving on to the Zygomycosis, also known as mucormycosis. These are infections caused from the molds from the order Mucorales. Some of the more commonly encountered include Absidia, Cunningamella, Mucor, and Rhizopus. And this can cause gastrointestinal, rhinocerebral, maxillofacial, pulmonary infections, especially in prolonged neutropenic patients, such as acute leukemics, and also seen in very poorly controlled diabetics. Okay, the mortality rate is roughly 44% in diabetics and roughly 66% in patients with malignancy. And this is an example here. You can see we tend to see with the zygomycoses are these large, ugly, wedge-shaped nodules, which you can see the earlier ones on the right, and after about a month of antifungal therapy, actually it's somewhat less ugly than it was, right? This is a patient who survived his Cunningamella pneumonia, but he required months and months and months of antifungal therapy to do so. Also wanted to mention the reverse halo sign. Okay, and as you can see here, remember when we were looking at the halo sign in Aspergillus, we had the solid center and haze around the outside. This is exactly the opposite, right? This is a more solid peripheral ring, and the center has more of a ground glass appearance, almost like a donut. This large series from MD Anderson, they saw this in 19% of their pulmonary zygomycoses. They saw it in one Aspergillus case, less than 1%. And it makes you wonder, maybe there was also zygomycoses present, they just weren't able to culture it out. And it's not seen with Fusariosis. And this is because you have this infarcted lung with greater hemorrhage in the peripheral solid ring than the center ground glass area. So if you see that, suspect zygomycoses. So what are our treatment options? Well, not as many as we'd like, right? I mean, so they're intrinsically resistant to fluconazole, itraconazole, voriconazole. So this is one where voriconazole prophylaxis can fail. Flucytosine, and the kind of candidans do not have single-agent activity. Okay. The most active agents we have are Amphotericin B, especially the lipid formulations, and posaconazole. There's some interesting studies in mice that have suggested that any of the three kind of candidans in combination with a polyene, amphotericin, actually may have a benefit in terms of response in these mice. We also there was a lot of interest in chelation therapy because elevated iron levels, high ferritin levels, are associated with an increased risk for zygomycotic infections. Right, it's a food source for this mold. So I thought as well, we know if you give deferoxamine, we actually have increased liberation of free iron, which actually makes things worse from a fungal risk standpoint. But we do have a newer agent called XJade or desferrizox, and there's actually in vitro activity versus against mucor. And because it actually more tightly binds the iron, so you actually have less free iron produced. And so the idea is you could starve the mold. Unfortunately, in the very small study that we have, and this is 20 patients with mucormycosis randomized to get ambisome plus or minus XJade, right? So an incredibly small study. We actually saw a higher mortality group in the XJade, in the combination group, than in the than in the single agent ambisome group. However, there was also significant, with the smaller numbers, you had significantly more patients with malignancies were in the combination group. So unfortunately, you'd expect them to have a higher mortality rate anyway. So all we can say from this is, in a very small study, they didn't see a dramatic benefit.
In that study,
Yeah.
the 20 patients.
Yeah, that was a multi-center study, by the way.
Voriconazole
Yep.
actually doesn't have patients who have diabetes. Is that what it is?
Yeah. Very poorly, patients who had been had their insulin control had, they're very poorly managed, or
A1C of 10 or higher.
Yeah. Okay. So while there are many other molds other fungi that we could talk about, I'm already pushing up against my limits for time. So I'm going to move on and kind of hit the antifungals. And this slide was just almost a joke, right? The ideal antifungal. Ideally, we'd like to have agents with broad spectrum of activity, but also have minimal or manageable toxicity, and we avoid things like infusion-related reactions, nephrotoxicity, hepatotoxicity, cardiotoxicity, minimum or manageable drug interactions, well-absorbed oral formulations, and IV formulations for our patients who can't take oral. And we would like all this for a low cost, please. Right? So obviously, I won't be talking about the ideal antifungal anymore. Conventional Amphotericin B, or Amphotericin B deoxycholate, used to be called Fungizone, is a polyene antifungal available as an IV formulation since the 1950s. And it was an important, critical drug, right? It's fungicidal, has a broad range of activity against yeasts and molds. I list the dosage for you there. It's a wide range of dose depending on whether you're talking about Candida albicans in the urine all the way up to a invasive mold infection. And Amphotericin B works by intercalating into the lipid bilayer, specifically binding to ergosterol in the fungus or cholesterol in us. Essentially creates a pore. You wind up with influx of extracellular fluid. You wind up with swelling and bursting, to use a scientific term, of the fungus. Now, amphotericin frequently started early enough back in the day because of its toxicity, concerns about its toxicity. It's commonly called Ampho-terrible, right? So thrombophlebitis, we had to use a central line or use a very dilute solution. Infusion reactions, also known as the shake and bake syndrome, right? Fevers, chills, rigors, acute dyspnea, hypoxia, nausea, vomiting, headache, arthralgias, myalgias, and you could get around some of this by premedicating patients with acetaminophen, diphenhydramine, hydrocortisone, and when the patient started rigoring, you could give them merperidine, morphine, or hydromorphone. We utilize hydromorphone. People have gotten away from using merperidine because of the potential neurotoxicity. And of course, the nephrotoxicity of amphotericin B, right? We get potassium and magnesium wasting, and we have the nephrotoxicity with a reduction in glomerular filtration rate, which can occur up to within 2 weeks and up to 80% of patients if you're at a high enough dose, as we saw in the Voriconazole study. Also, you damage the kidneys, you damage erythropoietin production, so you get chronic anemia as well. You can try to use saline loading, with 500 mLs of normal saline pre and post each dose to try to ameliorate this effect. But in order to try to get the benefit of amphotericin B with less toxicity, the lipid formulations were born. Right? And the idea was increase drug delivery to the sites of infection, reduce toxicity, and allow us to administer a full course of therapy, because often we had to switch people to every other day dosing of amphotericin, etc., because they just couldn't tolerate the toxicity. And currently there are 3 lipid formulations are available, right? Liposomal amphotericin B, amphotericin B lipid complex, and amphotericin B colloidal dispersion, and we'll talk about those. So this slide just gives you the general idea of the structure, the overall lipid superstructure of these formulations. What I will say is that that long ribbon-like formulation of Abelset is indeed the largest, with Amphotek's disc-like formulation being in the middle, and liposomal Amphotericin B should be much, much smaller on this slide, other than I think this graphic was produced by the makers of Ambisome, so they made it look big. But actually, since it's a true liposome, it's much, much smaller than these other structures. Now, in terms of infusion-related reactions of shake and bake syndrome, Amphotek ABCD as compared to conventional Amphotericin B, this is why you haven't probably never seen a patient on this drug, because they actually had a higher incidence of infusion-related reactions, including hypoxia, with ABCD than with conventional Amphotericin B. So, it's less nephrotoxic, but it's more infusion-related toxicity. So maybe if this was the only lipid formulation in existence, we would consider that trade-off, but it's not, so we don't. Conventional Ambisome, the lipid formulation, the liposomal formulation of Amphotericin B, has the lowest incidence of infusion-related reactions with the Amphotericin B products. Other than every 1 or 2 years, we'll see a patient receiving liposomal Amphotericin B as an atypical infusion reaction, and that's like a severe chest pain or back pain or hypoxia that occurs within minutes of the infusion starting. And actually, those patients can usually be transitioned over to Amphotericin B lipid complex, and they do fine. So that seems to be something that's somewhat specific to Ambisome. Rare, but for the most part, your general shake and bake, much lower incidence, other than rare cases of atypical reactions. Whereas,
Who sponsored those studies?
what's that?
Who sponsored those studies?
Pretty much all the Wingard study actually wasn't sponsored, right? All the other studies compared to conventional Amphotericin, one formulation of conventional Amphotericin B, those were all studies that were part of getting the drugs approved, right? So those were all manufacturer-based studies, yeah. For Ambisome, for ABCD. ABLC, Amphotericin B lipid complex, has a very comparable incidence of infusion-related reactions to conventional Amphotericin B. So it's not worse like ABCD, but it is not better like Ambisome. And then when you compare, so not surprisingly, when you compare the two to each other, you see more infusion-related reactions with Abelset versus Ambisome. And that's day one, and that's unpremedicated. Okay. Nephrotoxicity. All of these drugs are less nephrotoxic than conventional Amphotericin B. Otherwise, they wouldn't have been approved. I mean, that was why. Now, there is, again, going from the same study that Dr. Wingard and colleagues put together, where they're looking at patients with persistent neutropenic fever, by the way, this was the group they were studying. The randomized patients, they either got 3 mg per kg per day of Ambisome, 5 mg per kg per day of Ambisome, 5 mg per kg per day of Abelset. They didn't give 3 mg per kg of Abelset because there's no data with doses lower than 5 mg per kg per day with Abelset. And they did, in fact, see a lower incidence of nephrotoxicity in the Ambisome group than the Abelset group, although there wasn't a statistically significant difference in terms of severe nephrotoxicity. Okay, moving on. Flucytosine, nice simple chemical structures, kind of thing pharmacy students have to memorize. Available as an oral capsule since 1972. I really wish we had an IV formulation for this drug, but we don't. It's the only anti-metabolite with antifungal activity. It inhibits fungal protein synthesis by replacing uracil with 5-fluorouracil, which is one of my cytotoxic cancer drugs, in fungal RNA. And it inhibits thymidylate synthesis via 5-fluorodeoxyuridine monophosphate, which interferes with fungal DNA synthesis. It has in vitro activity against Cryptococcus neoformans and Candida species, with the exception of Candida krusei, and Aspergillosis species as well. So back in the day, we were known to occasionally use it in desperation adding 5-FC to patients who are dying of aspergillosis or candidiasis. Much less so these days. 5-FC is really not used as monotherapy. You have rapid induction of resistance by mutations in cytosine permease or cytosine deaminase enzymes. So that's why it's used in combination therapy almost exclusively. It's been suggested that it can be used for a true, like fungal urinary tract infection, like a Candida pyelonephritis, for example. But there's very little data out there. It makes a lot of sense. You get very high concentrations. Its predominant clinical use is combination with Amphotericin B for Cryptococcus. Bone marrow suppression is the primary toxicity we have to worry about with this agent, as it's a prodrug for 5-fluorouracil, neutropenia and thrombocytopenia more so than anemia, usually seen in the first 2 to 4 weeks, and is associated with elevated flucytosine levels, so therapeutic drug monitoring. It can be obtained for flucytosine, and it's a good idea for patients who are going to be on it for a prolonged course of therapy. And we have to adjust the dose for patients with renal dysfunction. Monitor patients for hepatotoxicity, GI toxicity, uncommon neurological toxicity, headache, drowsiness, confusion, hallucinations have been reported, and cutaneous reactions have been reported, although they're not common: rash, pruritus, hives, photosensitivity, and toxic epidermal necrolysis. Okay, moving on to the azole antifungals, I'm going to focus in on these 4: fluconazole, itraconazole, voriconazole, and posaconazole. I like to show them like this because voriconazole actually is derived from fluconazole by Pfizer, who makes both drugs, right? And posaconazole and itraconazole have a lot of structural similarity, and they have some similarity in terms of pharmacokinetics, including some stuff that clinicians actually care about. We know the azole antifungals work by inhibiting ergosterol synthesis. So fluconazole, as we talked about, predominantly active versus Candida, Cryptococcus, decreased activity against Galbrata, forget about Krusei, dose-dependent activity for mucocutaneous infections, 100 to 200 milligrams per day may be appropriate. For systemic infections, we're going to need at least 400 milligrams a day. 800 milligrams per day may be required to treat some of these serious Candida Galbrata infections if they're sensitive dose-dependent. Excellent bioavailability. Some drug interaction issues, some mild CYP450-3A4 inhibitor, and at high doses inhibits 2C9. And we do have to adjust for renal function. Itraconazole or Sporanox has been available as an oral capsule with erratic bioavailability since 1992. Then somebody figured out if they can give it in combination with hydroxypropyl beta-cyclodextrin, they can solubilize the oral solution. That came out in 1997. They even had an IV formulation with a cyclodextrin solubilizer, but it went off the market basically because it wasn't selling well enough, because voriconazole came on the market, ate up all their market share. Itraconazole is hepatically eliminated. Some weirdness in regards to itraconazole oral formulations. Capsules should be taken with food to get the best absorption. The oral solution should be taken on an empty stomach. And actually, the oral solution has significantly better absorption than the capsule. And if you give the oral solution on an empty stomach and the capsules with food, both of them optimally, you get an area under the curve almost twice as high. So the absorption is more reliable with the oral solution, even if it does taste pretty gross. So I would use the itraconazole oral solution over the capsules if you're treating a serious fungal infection. Be aware that itraconazole has been associated with heart failure. Right? So it's actually contraindicated in patients with ventricular dysfunction with CHF. And we actually know, like in healthy volunteers, if I give you IV itraconazole, your left ventricular ejection fraction will actually dip, but it will rapidly resolve before the next IV dose is given. However, in a 10-year span, the FDA received 58 cases of CHF reported associated with itraconazole. This hasn't been reported with the other azoles, so it does seem to be itraconazole specific. So be aware. GI complaints, oral solutions is somewhat unpalatable. It may lead to non-compliance, kind of a greasy taste. Look out for hepatotoxicity, rare rashes. IV itraconazole package insert used to say don't use it in patients with renal dysfunction. It's questionable and kind of academic because the drug's not available currently. Now let's talk about voriconazole and posaconazole. Voriconazole is available as 50 and 200 milligram tablets, or an oral suspension, or an IV with a sulfobutyl ether beta-cyclodextrin solubilizing agent. And posaconazole is currently only available as an oral solution, 200 milligrams per 5 mLs. Nice little clinical pearl. All of the liquid azoles are available in a 200 milligram per 5 ml concentration: fluconazole, itraconazole, voriconazole, posaconazole. Okay. So, voriconazole is approved for treatment of invasive aspergillosis, for candidemia and non-neutropenics, because that's the way they set up the study, for esophageal candidiasis, and for Cytosporium, apospermum, and Fusarium infections in intolerant or refractory patients, because it was a compassionate use study. As far as toxicity with voriconazole, it's good to warn your patients about the rule of 30, right? About 30% of patients will experience visual side effects. Usually they occur about 30 minutes after they take the drug and last for about 30 minutes. All right, this does not mean that your patient has a toxic voriconazole level. It's things like a little halo effect around certain objects, transient blurred vision, color changes, etc. They tend to be very minor floaters. They don't tend to require discontinuation of therapy. The site of action is the retina. By electroretinography, they can see that there's an effect in the retina. It resolves within 2 weeks after discontinuation of therapy, so this is a reversible phenomena. On the other hand, in that study we mentioned before, with voriconazole versus Amphotericin B, 13% of the patients who received voriconazole experienced hallucinations or confusion, versus 5% of the Amphotericin B patients. More about that in a moment. Be aware of dermatologic toxicities with voriconazole, mostly mild to moderate. However, you can also have cases of Stevens-Johnson syndrome, toxic epidermal necrolysis, erythema multiforme. Photosensitivity occurs with voriconazole with prolonged therapy, and these patients should avoid strong direct sunlight. Use a SPF 30 plus sunscreen if they're going to be out for a while. And if a rash develops while on voriconazole, we need to monitor it very carefully and consider discontinuation of voriconazole. Voriconazole can be hepatotoxic. All the azoles can cause QTc prolongation. There are uncommon reports of anaphylactoid reactions during voriconazole intravenous infusions, although much less common than with amphotericin formulations, certainly. I've yet to see one. Voriconazole pharmacokinetics, highly bioavailable, but if you take it with a fatty meal, you're going to reduce your absorption. So you should not eat for an hour before or after each dose of voriconazole. This is the exact opposite of posaconazole, as we'll get to in a moment. Absorption is not affected by pH, so absorption is not affected by antacids or H2 blockers or proton pump inhibitors. It's got an excellent volume of distribution, including quite good CNS penetration. Voriconazole is metabolized predominantly by CYP2C19, more so than by 2C9 or 3A4. It's important because there's a genetic polymorphism for CYP2C19. So about 15 to 20% people of Asian ancestry versus 3 to 5% of Caucasians, African Americans, exhibit a reduced clearance of voriconazole. So if you have the genetic predisposition and you are homozygous for reduced 2C19 activity, your voriconazole levels could be quadruple what the average person's levels are going to be. And if you're heterozygous for this, you can have double the voriconazole levels. And as we'll talk about, that's really significant because this drug has a relatively narrow therapeutic window. Voriconazole has saturable metabolism and nonlinear pharmacokinetics, like you learned about in pharmacology with phenytoin. Right? So if you double your dose, you more than double your concentrations. Voriconazole also inhibits 2C19, 2C9, and 3A4. It has a half-life on average about 6 hours, but the higher the concentration, the longer the half-life. Okay. In terms of voriconazole dosing in patients with hepatic dysfunction, its metabolism is not affected by patients having an elevated AST/ALT. It's been given with patients AST elevations up to 5 times the upper limits of normal in like compassionate use, like life or death scenarios. But obviously, it could aggravate the transaminitis. However, patients with elevated Child-Pugh scores, cirrhotic patients, in the package it clearly states that if your Child-Pugh score A or B, you need to give the standard loading dose, but give a 50% maintenance dose reduction. Okay, Child-Pugh score C, it just says hasn't been studied. Now, I want to warn you that Child-Pugh score is not validated for most of my patients who are not cirrhotic, but probably have like chemotherapy-associated acute liver dysfunction. And while they can have reduced voriconazole clearance, that the scoring system may not be the best way. So there's really there's an important role for therapeutic drug monitoring in patients we get to give voriconazole to who have hepatic dysfunction. There's been a lot of concern about voriconazole and renal insufficiency. IV voriconazole and renal insufficiency. It's in the package insert. The parent drug is voriconazole clearance is not affected by renal insufficiency. However, it's been stated that oral voriconazole may be preferred over IV if the creatinine clearance is less than 50. And this is based on the fact that the solubilizing agent is renally cleared. So you get elevated concentrations of the cytodextrin. And rats with hydrocyclodextrin exposed to hydrocyclodextrin wind up with a dose-related increase in the formation of vacuoles in their epithelia of the proximal renal tubules. We don't know what that significance is. Is it actually nephrotoxic? So what I can tell you is there have since been 2 studies that have retrospective analyses in ICU patients which have failed to show any increased renal or hepatic toxicity with IV voriconazole in patients with renal insufficiency. So hey, I always try to use oral voriconazole if the patient if I have a route available to me and they have a working GI tract, but because it's so well absorbed. But if they don't and they desperately need IV voriconazole, I will not I will not prevent giving them IV voriconazole just because of their renal insufficiency. Nor would I adjust the dose. Yeah.
Are you going to talk about the hallucination thing?
Yeah. Yeah, I'll talk about that a little more. Okay. Drug interactions. Voriconazole levels are reduced by enzyme inducers. So phenytoin, for example, you actually may have to as much as double your voriconazole dose to overcome this drug interaction. And be aware that voriconazole is going to inhibit phenytoin levels clearance, so you're going to actually have to reduce your phenytoin dose as well. Rifabutin plus voriconazole is also lots of fun because it's the same thing, right? Rifabutin reduces voriconazole concentration, so you have to increase by about 50%, but you're going to have to back off on your rifabutin dosing as well. Therapeutic drug monitoring for both agents might be indicated in this scenario. And rifampin, just forget about it. Okay. We suspect that carbamazepine and phenobarbital would have a negative effect on voriconazole concentrations as well. Definitely would require therapeutic drug monitoring. There's a minor increase in concentrations of voriconazole if patients receive omeprazole because omeprazole actually inhibits 2C19, but it's a relatively minor effect, generally not considered to be clinically relevant. Voriconazole inhibits omeprazole clearance as well, and you may want to cap your omeprazole dose at 20 milligrams a day. Lots of other drug interactions. Most of these are cytochrome P453A4 substrates. Voriconazole will inhibit their metabolism. I do want to mention warfarin as an interesting case because 3A4 is not the relevant enzyme, right? 2C9 is more important as far as the toxicity of warfarin. And voriconazole has a major drug interaction with warfarin, but posaconazole may be less significant because as we'll talk about, posaconazole is a 3A4 inhibitor purely. Voriconazole loading dose is recommended if you need to get a rapid your level to a therapeutic range rapidly. Otherwise, it can take up to day 6 to reach steady state. If you increase your dose from 200 milligrams to 300 milligrams POBID, your concentrations go up you expect them to go up about 3-fold. All right, so this is that nonlinear metabolism I was talking about. Therapeutic drug monitor with voriconazole. Okay, so in this series, they had 52 patients with invasive fungal infections, and they came up with a therapeutic range for voriconazole trough concentrations, 1 to 5.5 milligrams per liter. They had those patients who had trough concentration greater than 1 milligram per liter had an 88% treatment success versus 54% with lower concentrations. And interestingly, they had 6 patients in this group who had low voriconazole concentrations who were not experiencing treatment success. They bumped up their dose, and all 6 of those patients responded. Okay, 5 patients with Aspergillosis and 1 with Candidiasis. It's not a guarantee, but it does show that but just increasing voriconazole dose, if the levels are subtherapeutic, may be sufficient. Okay. In terms of toxicity of voriconazole, encephalopathy is concentration related. Okay, so patients who have concentrations less than 5.5 milligrams per liter have a very low chance of developing hallucinations with voriconazole. On the other hand, the incidence increases, linearly as the concentrations go higher. So patients who have a concentration of 8 or higher have about a 90% chance of developing hallucinations. All right, this would be like cute fuzzy bunny rabbits jumping around the room or a laser light show on the wall. Any number of really fascinating hallucinations that I've had patients tell me about. Okay. Right, so it depends on the indication or console, right? So if your patient's on it for prophylactic, first off, if I have a patient hallucinating on voriconazole, I want to get a level. Not for right now, but for the future. If I ever want to treat this patient with voriconazole, I want to know how high their level was when they had this intolerance. Especially because I'm usually talking about hyperchemics or high patient. This patient may have line of the pulmonary, pulmonary nodularity. Later down the road, I want to know if voriconazole is an option for them, right? So if it's prophylaxis, then I'll probably just switch from voriconazole if they have the normal intake. Since voriconazole does not have that particular side effect risk. Right. If on the other hand we're treating Fusarium, maybe we're increasing the reduced dose because voriconazole has absorption. So it depends on the severity of the reaction. Well, so that since I won't unfortunately I have to send out the levels, so I won't get the levels back for 4 or 5 days, right? I won't know exactly how high they might be. So that's a problem. So usually if the symptoms are relatively, this almost becomes a negotiation with the patient, right? What they can tolerate, and how critical it is for them to stay on their voriconazole. So if they're on 300 milligrams BID, I might drop them back to 250 BID. But if the patients are on the verge of refusing to take the drug, again, I might drop them down to 200 BID. So I can't. Since I won't even have the level at this point, there won't be a magical way for me to know exactly how much is the right amount. I would, obviously we'd prefer to back it down gradually because we'll have less chance of dropping into subtherapeutic concentrations. But again, you can also run into situations where patients like, I'm not going through that again. And that is something that that's why you don't always see us loading people over at Moffitt, because we had some people who overshoot with a load, and then right off the bat they're refusing to take the voriconazole anymore. So, yes, we absolutely will load somebody who has a definitive, invasive fungal infection with associated symptomatology. But if there's a nodule that we found in a routine CT scan, patient's completely asymptomatic right now, we need to treat it, but it's critical that we load them up. We may elect not to, particularly in elderly patients who seem to be more susceptible to this.
Essentially, the side effect is reversible if you stop the drug or reduce
It
it.
is. Now, the higher the concentration of the drug, in other words, the poorer the metabolizer, the the longer the half-life, the longer it takes to resolve. So that's the caveat. It can go away within it can go away within a day, or it can take 2 to 3 days to resolve, depending on just how high the concentration was at the onset. There's not a good correlation between hepatotoxicity and voriconazole concentrations. Not a statistically significant one anyway in this series. And interestingly, there was patients with elevated concentrations were more likely to be on omeprazole. Because I mentioned omeprazole can inhibit 2C19. So if you're a slow metabolizer of 2C19 anyway, and then you get omeprazole, that might be enough to that might be more significant in that subset of patients. The standard dosing of voriconazole, 6 mg per kg, Q12 times 2, and then 4 mg per kg. Q12 for invasive fungal infections. For candidemia, it was 3 mg per kg, Q12 that was studied. And we'll check a voriconazole level in 5 to 7 days and adjust dosing to achieve a trough of 1 to 5.5 milligrams per liter. If I can't get a trough concentration, I will accept a random level of 2 to 6 milligrams per liter. And prophylaxis, the standard dose is optional loading dose of 400 milligrams PO/BID times 2 doses, followed by 200 milligrams PO/BID. Sometimes that's a lot lower on the milligram per kilogram basis, right? So I have been known to cheat in particularly large patients using adjusted body weight, give them a 3 mg per kg adjusted body weight dose. But alternatively, you can give them a lower dose and just check a voriconazole level as long as you're going to get a rapid turnaround time on that. Okay, posaconazole is approved for prophylaxis of Aspergillosis and Candida infections in highly immunocompromised patients, such as our acute prolonged neutropenic acute leukemics and patients with graft-versus-host disease on high-dose corticosteroids. All right, 200 milligrams 3 times a day is the dose. It's also FDA approved for treatment of oral pharyngeal candidiasis, including oral pharyngeal candidiasis refractory to itraconazole and or fluconazole. So it's an option out there. It's been used as salvage therapy for aspergillosis and zygomycosis. Some clinical pearls. Absorption is a real issue with posaconazole oral solution. So we know that gastric pH is important. We know that if you add ginger ale with carbonic acid, you increase your concentration significantly, almost doubling. We know that if you give a proton pump inhibitor and reduce gastric acidity, that you substantially reduce your concentrations, and that the effect can't be completely reversed by just giving the patient ginger ale. It's now in the package insert recommending not, that it's to, if possible, avoid use in combination with proton pump inhibitors for that reason. We know that the dosing is important. Remember, voriconazole, saturable metabolism for voriconazole, but excellent absorption. Posaconazole, saturable absorption, right? So you only can get absorbed so much at a time. So giving 400 milligrams twice a day, you get lower concentrations than 200 milligrams 4 times a day, assuming adequate compliance, right? Which obviously you lose compliance when you go from BID to 4 times a day. Also, it matters whether you take this with food or not. So it's recommended to take with a full meal. Actually, ideally a fatty meal. But we do know that you can also get adequate concentrations by taking it with Boost or Ensure or other nutritional supplements. Okay. For prophylaxis, it's not very clear that concentrations matter. Okay. For one thing, the concentration of the blood does not correlate well with the tissue concentrations of posaconazole, less so than with voriconazole. Right? It's a larger, even more lipophilic molecule. It tends to like to accumulate within the cell membranes, and so it doesn't. That relationship isn't great. So, in the prophylaxis study, they didn't see a correlation. People who had really low concentrations didn't necessarily get invasive fungal infections. But at this point, I worry somewhat less about maximizing posaconazole absorption when we're using it prophylactically than I do when we're trying to use it therapeutically. But in any case, I try to get people off proton pump inhibitors if possible, because most of these people don't even need to be on proton pump inhibitors in the first place. H2 blockers, though, were not associated with reduced concentrations, so that's an option. Posaconazole is metabolized by glucuronidation. It doesn't have the cytochrome P450 metabolites. So there's a statement saying PK data not sufficient to determine if dose reduction is required for hepatic dysfunction. When you look at the graphs, there's really no major difference between various levels of Child-Pugh scores in posaconazole. So if you give posaconazole, if you elect to give it to a patient with hepatic dysfunction, use the same dose, standard dosing. Obviously, monitor the patient closely to see if the drug aggravates the patient's baseline hepatic dysfunction. It inhibits cytochrome P450 only, unlike voriconazole, which affects multiple enzymes, and exactly like itraconazole, which it's chemically related to. Excellent volume of distribution, seems to have some activity against CNS infections as well. Much longer half-life, average half-life of about 35 hours, range of 20 to 66. So, in regards to the half-life, there's good and bad, right? Takes a while to reach steady state. If you miss one dose, not a big deal. But if you need to stop the drug before an interacting drug, that can be a problem. Therapeutic drug monitoring with posaconazole, I'm not a big fan of it. This is the only data I saw that suggested that there may be some role. Patients who had, in this Aspergillosis salvage study, patients who had concentrations of greater than 1,000 had the highest response rates, and those that essentially had undetectable levels had lower response rates. Dosing 200 milligrams 3 times a day with meals or a nutritional supplement such as Ensure Plus. Consider switching to voriconazole if patients have poor oral intake and are unlikely to absorb the drug adequately. Treat invasive fungal infections with 200 milligrams POQID. Meals or supplement as an inpatient. You may elect to discharge them on 400 milligrams twice a day with meals because of compliance concerns with the 4 times a day dosing. Avoid concurrent proton pump inhibitors if possible. And another trick is to use vitamin C ascorbic acid as another acidifying agent to improve your absorption. Not a dose adjusted for renal or hepatic insufficiency. One thing I would say in passing on posaconazole is hopefully within the year we will have a new oral formulation out that will be far more reliable and the absorption is much more consistent and not reliant on stomach acid. The echinocandins inhibit synthesis of beta-1,3-D glucan, the cell wall. They're fungicidal against Candida because the cell wall is loaded, beta-1,3-D glucan. Fungistatic against Aspergillus because only the apical tips of those filaments are loaded with beta-1,3-D glucan. We have caspofungin or cancitis, approved for esophageal candidiasis, candidemia, disseminated candidiasis, salvage therapy for invasive aspergillosis and for persistent neutropenic fever. 70 milligrams a day on day 1 and 50 milligrams a day thereafter. You may have to bump it up to 70 milligrams per day if a patient's on enzyme inducers. Consider 35 milligrams per day if you have patients with moderate to severe hepatic impairment, and increased risk of LFT abnormalities in patients on cyclosporin. Mycofungin or mycamine has a drug interaction with sirolimus. You can see an increase in AUC that we can monitor levels and manage that. Nifedipine, you might see a slight increase there, monitor blood pressure, but very few other interactions. It's FDA approved for esophageal candidiasis and for prophylaxis of Candida infections in stem cell transplant patients. For esophageal candidiasis, it's approved at 150 milligrams a day. For prophylaxis, it's approved at 50. For candidemia and invasive candidiasis, we know that 100 milligrams of mycofungin is equivalently effective to 150, is equivalently effective to standard dose caspofungin. For salvage therapy for invasive aspergillosis, there's just one study which was not very rigorous, but based on the data from that trial, either alone or in combination, we use 150 milligrams Q24 mycofungin when we're trying to suppress aspergillus. No loading doses required, and no real dose adjustments. Nidal fungin, or Araxis, is the most recent FDA-approved echinocandin. They're all only available as IV formulations. This requires reconstitution with 20% dehydrated ethanol and water. Undergoes slow chemical degradation under physiological conditions, so no change in PK even for severe hepatic dysfunction. No PK drug interactions have been observed. FDA approved for esophageal candidiasis at 100 times 1 than 50 a day. Candidemia at 200 times 1 than 100 a day. And it's been studied in the combination with voriconazole for invasive aspergillosis, as I mentioned before, 200 times 1 and then 100 per day. Okay, so thank you guys for your time. And are there any questions that you have?
No.
Okay.
Thank you.
Thank you.